In this section, we will be taking a look at the concept of sensory perception. The objectives are that we are going to be taking a look at the pathophysiology, etiology, clinical manifestations, and causes of hearing impairment, cataracts, glaucoma, and macular degeneration. And we will be taking a look at the student learning outcomes of providing safe, patient-centered, evidence-based nursing care for chronic and vulnerable populations guided by the Caritas philosophy, demonstrating critical thinking and clinical reasoning when providing quality patient care in community-based settings, communicate effectively with patients, families, and members of the interprofessional team, and manage care for clients and groups in diverse settings. Age-related macular degeneration is the leading cause of blindness in adults over the age of 60, and it does affect the macula of the eye, and that is the ability to filter light. So it does end up affecting central vision and visual acuity. The risk factors are listed, and you can take a look at those. So age-related macular degeneration is kind of the umbrella term for macular degeneration, and then there are two types underneath there. There is the non-exudative and the exudative form of macular degeneration. And you can see the differences listed. The non-exudative is a dry form. It results from atrophy of the eye, and degeneration typically is result from drusen accumulation. It's actually the most common, but it is the less severe of the two forms. It progresses slowly, and there is no treatment for it. On the other hand, the exudative is when blood leaks into the vessels and it develops scar tissue. It is less common, but much more severe, as 90% of the vision is lost. There's an Amsler grid where you can have them take a look at. It's a grid of lines, and when a person with this form of macular degeneration looks at it, the lines appear wavy versus straight up and down. Treatment, there are treatment options. It's centered on laser therapy, injections into those blood vessels to try to decrease the amount that they are leaking. So it actually will not necessarily correct the problem, but it will further decompensate, or avoid it from further decompensating, sorry. So when we're looking at prevention, especially with older adults, it's extremely important that with any of the visual sensory perception issues, that they follow up with regular ophthalmic examinations. Ultraviolet protection, so they're wearing sun hats, sunglasses outside, and this actually starts as early as the 20s. So right now you can actually work to protect your eyes for the future, and make sure you're wearing your sunglasses, even in the car, because it can reflect from the windshield. Smoking is a risk factor. Diet and exercise will help to promote eye function, especially diets high in antioxidants. This is vitamin C, E, zinc as well. Cataracts is when there's an opacity of the lens. It's almost like there's a film covering their eye and they see everything very blurry. It is the leading cause of blindness. And the symptoms are going to be blurry vision, a glare around objects, halos around objects, double vision. They have difficulty sensing the contrasting colors, which is a safety issue as far as protection in the home environment, that there's not the flooring, because they'll be at higher risk for falls. The flooring isn't designed that they won't be able to see steps, so it'll decrease the risk of falls. So actually putting like red tape on steps sometimes helps, because then they can actually differentiate depth and the contrast. And then also poor night vision. older adults are actually at the same risk category for driving as teenagers are. And a lot of it is due to the sensory perception changes that they experience when they become older. A lot of this is normal changes that occur to their eyes with the decreased number of photoreceptors that they have in the retina, their ability for the contrasting colors, the glare, all of those are normal. However, cataracts, macular degeneration, and glaucoma are pathological processes and are not normal changes of aging. So you take a look, again, the risk factors, very similar in some ways to the risk factors for macular degeneration. However, the use of corticosteroids is significant with cataract formation. So if you do have a patient that is on long-term corticosteroids, that you really want to educate them about other ways that they can prevent cataract formation. And then Caucasians are at higher risk for cataracts as well. Treatment is centered around surgical procedures. Typically, they will not perform a cataract surgery unless it is greatly impairing quality of life issues. Once quality of life is disrupted, as far as safety or just patient preference that is interfering with their activities of daily living, they will go ahead and they remove the affected lens of the cataract, and then they actually insert an artificial lens. It's important with any kind of eye surgical procedures that you educate them about avoiding any kind of activities that are going to increase the intraocular pressure. So this is bending at their waist, lifting, again, prevention is going to center around that ultraviolet protection, smoking, and again, diets high in antioxidants as well. Glaucoma is a result of optic nerve damage due to increase in the intraocular pressure. What ends up happening in the eye is the aqueous humor. It will increase in production, or the outflow channels are blocked. So it's usually one of those two things, either increased production or decrease outflow. And what it does is it will increase the intraocular pressure, and a buildup of pressure over time will actually damage that optic nerve. It is the leading cause of blindness. Typically, you want your intraocular pressure to be between 12 to 15 millimeters of mercury. Anything greater than that, then they're starting to suspect that the patient is at risk for glaucoma. So the risk factors, again, are listed. That long-term steroid use, African Americans are at higher risk with glaucoma, and any prior eye injuries. Glaucoma does affect the person's peripheral vision as well. There's two different types. There's open angle and angle closure. Open angle is where that flow of the aqueous humor is slowed. It is a gradual process, and it is painless. Usually they will not realize that this is even occurring until they start to lose some of that peripheral vision. Angle closure, on the other hand, it is a medical emergency because there is a sudden stop of that flow of the aqueous humor, and if it is not corrected immediately, it can actually lead to blindness relatively fast. So, angle closure, ophthalmic emergency, it needs to be treated promptly in order to avoid blindness from occurring. The management is going to center around lowering that intraocular pressure and preventing further vision loss. There are medications. I just did a summary on this slide, but you are going to want to refer to the medication table in your textbook on page 1322, and it does list all of the classifications and some examples of the medications, what their mechanism of action is, and then the nursing considerations. So you do want to pay attention to how these medications are working. The beta blockers are going to decrease that production of the aqueous humor, therefore in turn lowering the intraocular pressure. Your miotics, the cholinergic agonists, they actually allow decreased pressure on the outflow channels, so it actually promotes more drainage of the aqueous humor again. That is going to lower the intraocular pressure. And then the alpha adrenergic agonists actually decrease the production and increase the drainage. You do want to pay attention to when you would give each of the types of eye drops. Like beta blockers should be avoided with anybody with respiratory conditions, asthma, COPD, heart blocks, heart failure, because of that beta blocking effect on those beta 1s and beta 2s. And then your alpha adrenergic agonists, they are going to want to be avoided for anybody that has hypertension and coronary artery disease, dysrhythmias. So you want to know if they do have one of those conditions, what medication would you expect to be prescribed. And then as a last resort, they may do laser surgery, but the majority of the time, glaucoma is managed through the medication with the eye drops. Those individuals that experience a hearing loss have a number of factors to take into consideration. Social isolation that occurs, and also safety. So if they're not able to hear properly, then can they hear their telephones? Can they hear doorbells? Can they hear smoke detectors and carbon monoxide detectors going off? Security alarms going off? So it becomes a safety issue as well. Normal changes of aging. Older adults will actually have a decreased number of cilia in their ear canal, which actually will, the cilia help with the transmission of the sound to the cochlea of the ear, the inner ear. So there's decreased number of the cilia. There's also changes that occur to that cochlea of the ear as well. So it makes it more difficult for them to hear at a level that normal adults can. The risk factors are listed. You can take a look at them. We'll be reviewing which risk factors are associated with which type of hearing loss on the upcoming slides. Two different types of hearing loss, conductive and sensory neuro. You want to know the difference as far as where in the ear it is located, how it affects the sound transmission, what ranges are affected, and then also the causes. So conductive hearing loss is mainly external and middle ear, and the primary cause in older adults is impacted cerumen, which is the earwax. Once you resolve that impaction through irrigation, then they will regain their normal level of hearing. Sensory neuro, on the other hand, is due to typically damage done to that inner ear through noise exposure. The presbycusis is a normal process that occurs with the ears with aging, where they actually do lose some hearing ability. And then it affects the high pitch tones. So sensory neuro, inner ear, primary cause is the presbycusis and noise exposure, versus the conductive of external and middle ear and caused by impacted cerumen. Okay, a couple nursing assessments that could be done. The whisper test is where you stand a couple of feet behind the patient on one side or the other, and then you whisper a 2-syllable word, like baseball 99, and then you want to test each ear individually to see that they heard you and that it's equal on both sides. The Weber test is where you strike a tuning fork, you place it on the top of their head on the bone, and you ask them if they can hear or feel that vibration equally in both ears. And that is what you want. That's a normal test result. If it is lateralized or they hear it more on the affected ear, it's a conductive hearing loss. If they hear the sound better in the unaffected ear, then it is a sensory neuro loss. So you may be asking, well, how do I know if it's an affected or an uninfected ear? Which is a great question. The next step would be performing the Rhine test, and this is just looking at the conductive hearing loss. And what this is again, you strike that tuning fork, you put it on the mastoid process of the bone right behind the ear, and again, you tell them to let you know when they stop sensing that vibration. And when they stop sensing that vibration, you take it off of the bone without touching the prongs and move it to the front of their ear. And they should be able to hear the air conduction twice as long as the bone conduction. If that is occurring, then it's a normal test. If that does not occur and the bone conduction is actually longer than the air conduction, then it's a conductive hearing loss. So you really need to do the Weber and the Rhine in order to figure out which ear is affected and what type of hearing loss that they would be experiencing.